From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Healthtech.
Thank you and good morning. I'm Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen. Good morning. Welcome to Diagnosing Healthtech. I am joined by Carolyn Bringerhoff. Carolyn is the Director of Cloud Enablement. Is that the right title, Carolyn?
Director of Cloud Delivery. In other words, I lead the delivery team for our Redox Nova product, which takes any kind of healthcare data, patient data that you're collecting, normalizes it and sends it into your Firestore of choice. So very good for things like pop health, longitudinal patient record tracking, and closing care gaps. So lots of different applications there when you're taking disparate data and putting it in one place.
Well, welcome, Carolyn. Thank you for joining us. And it's our pleasure today to welcome Tom Scully. Tom, good morning and welcome.
Morning. I'm still using a slide rule, so I'm not sure Carolyn can help me much.
Well, I think Tom understates himself. Tom is a general partner with Welsh, Carson, Anderson, and Stowe. They are one of the most active investors in healthcare. From 2001 to 2004, Tom was the administrator at CMS. He was instrumental in the passage of the Medicare Advantage and Medicare Part D drug plan. Tom also, a little bit lesser known, was one of the people to initiate the first public disclosure and reporting of quality data in Medicare. And Tom, would you say it's fair to say you really got your start in healthcare, not in government, but in healthcare in kind of the late 80s, early 90s when you were at OMB?
Yep. Worked in the Senate for 6 years and then worked in the Bush campaign 88 for a year and was the OMB and then White House healthcare person from 89 to 93. And then we lost, unfortunately. And I had to find something else to do for 10 years though.
Well, Tom is really a font of knowledge and expertise in healthcare. So we appreciate you joining us. So Tom, I wanted to start with a more theoretical issue because there's a lot of people who come at it from different sides. What do you see kind of as the role of government in healthcare, and what's the best thing that government can do to help healthcare, given all your experience?
Well, that could kill a couple hours. So, I think the role in healthcare it's changed over the years. So my first job working for Bush Sr. was passing RBRBS. So obviously with a bipartisan group of Democrats back in 1989. So at the time I thought, because I didn't know any better, that government price fixing was a good thing. And that was kind of single payer. And that paying every doc, we used to pay reasonable customary before that, and paying every doc the same amount. Every hospital I was involved in DRGs seemed to make sense till I got a few years into it and realized that paying every doc in the country the same thing, whether the top of their class, the dean of Harvard Med School or the just graduate of the University of Western Guatemala, not a good idea in any sector to pay everybody the same thing. So I was actually a big fan, and I was very involved in creating RBRBS. As I got further into it, I just don't think price fixing as well as it may be intended. And, I respect Don Berwick and guys like that I just think it's, in the history of mankind and certainly the United States, there's no part of any service world where the government setting prices and delivering the service directly works. Doesn't work. People think you're crazy if you went out and, said, let's get rid of the Safeways and Acme's and have the Department of Agriculture deliver food and fix prices. And, we used to do that with public housing and went to private housing. So I just don't think there's any example where in the long run, government price fixing works. So my view is much more priority. The goal for the government is to structure markets, figure out who's going to get subsidized, and make sure that the rules are fair so people can compete fairly. So I actually was relatively supportive of Obamacare. I thought the subsidies were too big. So I was one of the few Republicans because, I think exchanges are the right way to go. I've always been a very big fan of the Federal Employee Health Benefits Plan. So in a perfect world, which probably won't happen, I was a federal employee for 20 years. I think we should offer, 15, 20 plans in every region, saying, Southwest, Pennsylvania or South or Philly. If you offer 15 or 20 plans like the Federal Employee Health Benefits Plan does, and whether you're Medicare or you're in Medicaid or you're commercial, in one plan, the subsidy level should depend on your income and your status and your work status. But, I think the government should exist to set fair rules, but I'm a very big believer that private capital And private delivery systems, whether nonprofit or for-profit, are a way better way to go than the government, basically being the provider. So that's in a nutshell. I'm a believer in well-regulated markets. How's that?
Okay. So taking a look at that, and given now where we are with Medicare Advantage, about 50% of Medicare, a number of pluses and minuses. Taking a look back from when the bill was written to where we are now, how would you evaluate the progress of Medicare Advantage, and where you think it is today?
Shockingly positive to my So when I came in to work for George W. Bush after working for his dad, and agreed to take the HCFA job, which was old name, it was called HCFA, so I changed the name to CMS. Medicare plus choice. So it's not like you asked me. I didn't invent Medicare. There were 50 people involved in creating Medicare Advantage. The reality is the program existed as Medicare plus choice through the 90s. With a well-intentioned set of reforms in 97, they screwed it up and basically completely miscalculated unintentionally the rates in urban areas and drove a lot in intention to drive a lot more money to rural areas where they would hope they would develop more managed care. They screwed up the rate formula. So between 97 and 2001, when I came in, it was done by Senators Domenici and Senator Durenberger, two great guys, now both passed away. People were getting out of Medicare. Private Medicare was toast, and I think we had 4% of people in Medicare plus choice when I came in, and every plan I knew all the plans. During the 90s, in between Bush administrations, I ran the Federation of American Hospitals. I was the CEO, so I knew the hospital politics and the Washington stuff, and I knew all the health plans. And every health plan wanted to get out of Medicare plus choice. So if you go back to 2000 and you asked Jack Rowe, who was running Aetna, or Mike McAllister, who's running Humana, they thought the Medicare business was terrible and they were going to get out of it. So when I came in with Bush, I said, look, I worked on the drug benefit for 20 years. So you're old enough maybe to remember the catastrophic benefit, which Reagan passed and was repealed over my dead body in 1989. Bush wanted to keep it. So the two reasons I went back were to help design a drug benefit and also to fix Medicare Advantage because the payment structure is screwed up. And not that I loved private Medicare, but I thought price fixing did not work. And the other major thing is that what most people still don't realize is Medigap is crap. It's not part of the Medicare program. It frequently has medical loss ratios of 60, 65%. So if you buy Medicare fee for service, unless your employer provides it, most people buy Medigap. So for me, I'm 66 years old. If I went and bought Medigap, it would cost me, my wife and I, about $700 a month. And it's not a good, and so, to me, I thought that we need to strengthen Medicare plus choice, fix it, clean it up, add a drug benefit, make it work better. And I think it's a much better alternative for the 50 or 60% of the population, usually lower income. They can't afford to pay $600 for Medigap. And I just think that Medigap, Medicare with high deductibles in the fee-for-service side, plus Part D, plus Medigap, for the vast bulk of Americans, is a much tougher choice to make than Medicare Advantage plan. You can complain that the networks are tighter and people have to make choices, but the average senior, including my in-laws and my parents, have both passed, but they would rather have a zero premium plan with some benefits and not have every provider in Philadelphia in their network than to pay $6 in their case, because Pennsylvania, by the way, does not have allows you to underwrite a Medigap. If they want to buy Medigap, they can't buy Medigap. It would cost them $30,000 a year. So my point is, I look at Medicare Advantage when we passed it as a way to clean up an option that most people under 65 have, which is to pick from among private plans, like the Federal Employee Health Benefits Plan. But that really, for the vast bulk of people who are not wealthy, it's just a much better economic choice. And I think that's why you've got 50% of people in the program, and it's going to get bigger and it's going to get higher. It's not that people love most people understand Medicare Advantage versus fee-for-service, how it works. They understand very clearly that your choice is Medicare plus $600 or $700 a Medigap for a couple, or I buy a Humana plan or a Blue Cross plan. And you can debate the payment and the appropriate payments, but the reason it's exploded is it's a much more rational choice for seniors. And in 2001, the choice stunk because the rates were terrible. Philadelphia example was 82% of fee-for-service in 2001 when I came in because of the way the rates had been screwed up. So there's basically nobody operating in Philly, and the ones that were independent Blue Cross wanted to get out. So I'm giving you too much information, but that was the rationale behind it. And I was the primary cook, I guess, at that point with CMS, and Mark McClellan was in the White House for the first year and a half before he left and went to FDA. So we spent a lot of time with Bush cooking it up. Obviously it took a ton of people on the Hill. We made up the name Medicare Advantage, and we lit the fuse, but it changed a lot over the years, and lots of members of Congress and lots of staff. Liz Fowler, who's still at CMI, was the chief staff person in the Senate, worked for Max Baucus. Mm-hmm. She's terrific. If you asked who really created Medicare Advantage, we probably cooked it up and Bush pushed it. But without Liz Fowler and, John Breaux and Bill Baucus, it would never happen. So, if you're looking for who deserves credit, back then everybody hated it. It was very controversial when I left, but now everybody loves it. So I think it was a very bipartisan effort. Senator Kennedy voted for it. He was very, very helpful.
Right. Let me ask one follow-up, and then I'll let Carolyn get a question in here. You said people don't really understand Medicare Advantage. What do you think, people are misunderstanding most about Medicare Advantage?
Everything. And Medicare.
Okay.
I'll give you the example. My 70-year-old brother, I'm 66, called me, the day before, the open season ended with his significant other on the phone. Oh my God, what do we do? I spent an hour and a half trying to explain the choices to him and coach him through it. And he's a smart guy. He's just confused. It's, as much as you try, it's confusing. It's hard. And I think some of the stuff that CMS fixed last month, which irritate a lot of people, but the broker incentives to steer people to certain plans are not helpful. So, it's confusing, and setting up incentive where brokers and other people are set up to, they want to help your mom or your dad make the right choice, give them tons of information, not steer them one place versus another, help them figure out where your docs are covered and which pharmacies you're going to be in. It's a big deal to seniors, but I think it's really hard. I can just tell you from my own family, I helped create these things and I get confused.
Right.
It's confusing and it's tough. And then people get angry. And then I say, well, you can get angry, but it's actually about a $17,000 annual subsidy for you. So, you may not like Medicare Advantage, but they're massive subsidies. People over 65, the average subsidy level, it depends on how old and sick you are, but it's generally about $17,000 a year. So, it's a pretty big income transfer, and the programs are great, but making them simple enough for seniors and their families to make sane, rational choices is not easy. But people are on the program. I like Chiquita, the current administrator, a lot. Sherry Rice is the senior career person that runs MA. Is awesome. She was my staff person with her husband at OMB in 1989. Believe it or not, that's how long she's been doing this. So, there's some very smart people at CMS working on it. Liz Fowler, as I mentioned, knows this program as well as anybody. So, Chiquita's great, but it's hard.
Right.
Yeah, I understand that. I find insurance confusing all around, even when I'm trying to figure out what plan I should be on. And I'm sure as anyone is trying to figure out what's right for them, projecting what kind of care they will need, understanding how that maps to the different options available is super challenging, and having someone to support along the way would be really helpful. I have two questions in my head. Earlier on, you talked a little bit about just general models and of insurances for governments, and I was curious to know, are there any other governments or countries out there that you feel model the best healthcare insurance model?
Yeah, Mars has a great one.
I'll take that as a no.
I've looked at a lot of, do I think anybody's perfect? No. So I don't know as much about all the international stuff as I probably should, but Uwe Reinhardt, who was a good friend of mine who passed away a few years ago, was kind of an expert on the stuff. He was a Princeton professor and probably knew as much as anything. So, he's German to start with. The Germans have an interesting system. The Dutch have an interesting system. I think what they do in both those cases most is they're kind of community-based. So they're kind of like almost community co-ops in each community, and the subsidies are run through that. But they also, going back and saying what's the best that we should mimic is impossible. You can't unravel. I've been doing this a long time. Change has to happen really slowly. So I was marginally involved, which people don't know now, with Social Security retirement age went from 65 to 67. You could get killed doing that. But Moynihan and Reagan and a few other people very quietly said, let's raise it 1 month a year for 24 years. And that's very quietly. So now the retirement age is effectively 67, will be next year. And everybody's lived through it. But if you went out and made a big announcement that day, we're raising the retirement age by 2 years, we're getting killed. So we went out tomorrow and said, let's get rid of all these subsidies. Let's get rid of, IME and GME and 340B and everything else that goes to hospitals or health plans, or let's get rid of risk adjustment. You'd have riots. It's 20% of the GDP. It's incredibly arcane. Everybody's well-intentioned, but the money moves around in bizarre, almost unmanageable ways. Even the states, if you look what the states do in provider taxes, which there's not a human being in the world that can tell you what's going on in all 50 states on their Medicaid financing. It just doesn't exist. It's CMS. trying to say, hey, let's take all this money and put it in one big pot of 20 and make it work better, it's politically impossible. It's just too many. So it's got to be done slowly and gradually. And I personally think the Medicare Advantage and the exchanges, my problem with the exchanges, some of my old friends in the Clinton administration don't like this or Obama when I say it, but I like the exchanges. I think it's the right model. The issue for me is who do you want to subsidize? I think subsidizing 400% of poverty or half the population, it's just very hard to come up with a social services program that subsidizes half the population. You're collecting taxes from one group of people and redistributing to them on the other hand. So my issue is not with the exchanges, it's whether we wanted to go to 300% of poverty back when Obama was being passed, at least the moderate Republicans that were involved in it. And the Democrats used to want to go to 400% of poverty. And people would say, well, there's not that big a difference. Well, guess what? There's like 70 million people between 3 and 4% of poverty. It's a big deal. So to me, the issue is the market structure that most Democrats should come around to. Even though Republicans and Democrats like to say, let's blow up Obamacare, it's terrible. And Republicans want to, Democrats want to blow up MA, because originally they did, because Republicans created it. They're very similar models. The issue is, who do you subsidize how much? So giving people a choice of multiple plans, the real tough part is, who do you subsidize how much? And I think generally Democrats want to subsidize a lot more people, and Republicans want to stick to the lower end of the income stream. And I think when you got a $2.5 trillion budget deficit, it's wise to go a little slow.
Got it.
But I think the structure where we're heading is gradually, incrementally towards what I think is the Federal Employee Health Benefits Plan, which is people picking between multiple private plans. And I think it's a better way to go than the government. And, if you look at Medicaid, there's almost no state left that has Medicaid fee-for-service of significance. The most liberal Democratic states were the first ones to go to Medicaid managed care, because it's just simpler and more rational for California or Oregon or, pick your state, to give Centene and Molina and the Blue Cross plan X number of dollars and say, call me next year, than it is to go out and run a fee-for-service plan. And it's just simple management economics.
Got it. That leads well into my second question for you. In the current landscape, you've said so much has changed with Medicare Advantage since you left. I'm sure you're tracking it. Do you have specific reforms or improvements that you would suggest for the program?
Yeah, now that I'm old and retired and not going to get killed by any of my friends for saying this, I think I'm not retired yet, so I could be fired from Welsh Carson today for saying this. Look, I think that Medicare Advantage was created, at least in my view, and we did create it in 2001, 2002, and everyone remembers that, 2003, when we were cooking it up, to basically be a high volume, as was Part D, a high volume, low margin government plan. And the design was you'd have an 85% MLR and a 10% ALR, and you make a 5% margin, which, if you're a high volume player like United or Humana, it's a hell of a great business. I don't blame the plans, but over the years, the economics, plans and shareholders, whether you're nonprofit or for-profit, are going to follow, I don't care if you're UPMC or United, you're going to do the best you can to work the program, make a margin. So I think risk adjustment is totally well-intentioned. If you really believe in private health plans, you have to do risk adjustment. I was involved in cooking up risk adjustment. The staff, my staff did it when I was there with the first risk adjustment. I think risk adjustment is wonderful, but you can't have everybody have a 1.2 or 1.4. Okay, risk adjustment, if you go through the exchanges with the states, like I was very involved for years with CareSource in Ohio. If you go to Ohio, they take everybody's Medicaid risk scores, they throw it in a pot, and they call you back, say, here's your risk score. If you don't like it, tough. You don't get to declare your own risk score. I mean, risk adjustment is intended to be a 1.0 pot. Somebody's going to be a 1.1, somebody else has got to be a 0.9. And because of the way it's turned out, everybody can pedal faster and do better, and that's caused a lot of strife for CMS. And I think risk adjustment is terrific, but it's gotten a little out of control. So I think CMS has been wise to keep looking at that. It's got to be changed slowly, or you're going to blow up the program. I think what they did on the broker stuff last week was great. Probably my pet peeve, which probably no Democrat would agree with, is the drug benefit's been destroyed. So I'm a big opponent of fixing prices for drugs, and you pick 10 or 20 or 30, because the original design of Part D, which I was heavily involved with, people complain about it, covered 13 million poor people, had no co-payments, no deductibles, no costs. 13 million poor seniors had zero. That was the design. Above that, it had very significant co-payments, deductibles, and the donut hole was intentional, at least from our point of view. Because when we want people to have some skin in the game as they start spending money on drugs, that high cost drugs, they would ask questions and switch to generics. And I think the program kicked in 2006. 2006 and 2007, I believe generic utilization tripled, which is exactly what we wanted. Somebody's going to look at a drug and say, wow, why the hell am I paying for Nexium when I can take Prilosec, which was two big drugs back then. One's $70 a month and one's $1.50 a month. We wanted people who are not poor to feel some pain. Unfortunately, in my opinion, the Democrats, with God bless them, they're trying to do the right thing, along with the drug companies, came in and said, let's fill in the donut hole. Let's cover everybody. Let's make it's terrible. All these seniors have to pay all this money for drugs. Well, guess what? When you fill in the donut hole and they're feeling no pain, and they see almost nothing up to a very high catastrophic stop loss, the government's paying the bills, and guess what happens? Drug prices get jacked up, and the hospital companies are very happy. I mean, the drug companies are really happy to blow through your $7,500 deductible immediately because you go right into the CMS Treasury pocketbook. So I personally think they've destroyed the incentives of trying to get people to make rational choices based on economics who are not poor. Were very intentional. So maybe you could have made the donut hole a little smaller, but when you take away any consumer interest in making a rational choice, you've blown up the system. So, I don't like price fixing at all, as I said at the start, but I think where we are right now, I don't know what else they have to do. I mean, the CMS might as well, the drug sector's, in my opinion, out of control. At some point, I would much prefer market economics to solve some of these problems. But I think well-intentioned people in Congress, along with the drug sector, who I don't really know if they intended or not, has totally screwed up any incentive for consumers to actually control the cost of Medicare drugs. So that's my pet peeve. And by the way, Steve Ubel, who runs Pharma, who I love, was my deputy at the Federation. So I don't mean to pick on Pharma, but I just think they've worked themselves into a hole where the argument against drug price fixing is, the mechanism we tried to cook up to make a market for drug pricing back in 2003 and 4 has been completely gutted, in my opinion.
So let me stay on that for a minute, Tom, in the sense of, what you're arguing is that there's, you've got to have some skin in the game to reduce overutilization. One of the complaints against, MA has been that the plans are using prior auth to depress utilization and therefore jack up profits. So is there a change?
They should be using prior auth, and their incentive to jack up profits should be, is your net profit going to be because you're really good 4% or 7%? I mean, I mentioned earlier, if you have an MLR of 85 and an ALR, maybe you can have a really efficient plan that runs an ALR of 5 or 6 or 7. Probably not, but you can't. The profit shouldn't be unlimited. And I don't, plans use utilization. In a lot of cases, in fee-for-service is out of control. I started a company 10 years ago. You probably never heard of it. It's now part of United, called Nava Health, 12 years ago.
Yeah.
And Nava Health's gotten a lot of crap but you know what? The reason we did it was, when I knew this from CMS, the reason I did it, I started from scratch. Clay Richards was the CEO for years. Nursing homes would get a patient coming out of a hospital, and because the Medicare fee-for-service days were, you get 20 days like Pavlov's bell. You come out of a hospital, you get 20 days in the nursing home, ding, 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 and you stay there. And the nursing homes would keep them for 20 days. And if you're Humana or United, you call them, they'd say, we can't let that patient out. Medicare requires to keep us for 20 days. Complete bullshit. That was not at all true. Nava Health very simply started calling them nursing homes and saying, we're only going to include certain ones in our network that are higher quality. And by the way, we'll send you more if you get the patient that shouldn't be there for 20 days out in 12 and send them home with a rehab therapist. It was the right thing to do. It was massive overutilization in the nursing home sector. And the nursing homes hated it, but it was absolutely the right thing to do. Now that more recently there have been some complaints about Nava Health theoretically that United's being too aggressive on doing this. But, I'm on the board of Select Medical, one of the bigger specialty hospitals, and they get upset about it because, patients that are going to rehab hospitals have to jump through a lot of hoops. But, utilization review is the right thing to do. Taking it too far.
Let me interrupt for a second. How do you strike the, utilization review? Totally agree. It's the right thing to do. You have to manage overutilization. But do you think the plans have gone too far in one direction and not struck the right balance between utilization review and, and there's, obviously lawsuits that'll have to play out in the courts. Between that and just strictly denying care at the expense of the patients?
I don't know. I mean, the reality is, you're basically, the simple economics of this are, if you have, let's say it's, just to round it up, let's say it's $15,000 a year per person.
Right.
You're spending on Medicare. And your real choice here between fee-for-service and Medicare Advantage is Blue Cross of Florida, and they're great, which most people don't know, probably runs 80% of the Medicare fee-for-service program. They bought up all the contractors, all the MACs, they're all part of Blue Cross of Florida, Guide Will. So you're giving them $15,000 a year and saying, here's the Treasury checkbook, play all these claims. We're going to pay you 1.5%, or it's like 1.2% to process claims. No utilization review, no nothing. Just crank out the money from the Treasury. As a taxpayer, is that better? Would you rather pay them $15,000 a year and say to Blue Cross of Florida, why don't you take risk and be an MA plan? You're allowed to make a 5 or 6% net margin. You know, you're gonna do everything to make utilization better. Call me next year. I think that's a better answer. But you also have to oversee them to make sure that they're not going too far in utilization review. And I think CMS tries to do that. You know, am I inside these plans to know what they're doing? I don't. You know, I've had the fight with Independence Blue Cross and Humana and others from my family to get people into rehab hospitals and make the arguments. And, you know, it's sometimes difficult and pain in the neck, but there used to be a hell of a lot of overutilization. And if you're trying to make, you know, costs be responsible, my view is let the plans do their job and regulate them aggressively, which I think, you know, they don't like to be regulated. They don't like to be told they can't have more than a certain MLR and there's certain things they can't do. But, you know, it's a government business. And, you know, I'm sure that Bruce Broussard, whoever, you know, who's an old friend of ours, you know, they know that. I mean, they're going to do as much as they can to make a margin for their, whether it's nonprofit or for-profit, and to do the best they can and get more patients. And CMS has to be active in making sure that they set the right incentives.
Are there, and Carolyn, I'll let you step in after this. Are there things on prior auth that you think they should do, or that CMS should do to make it a little, not a little fairer, but a little more transparent?
You know, you can't hire somebody and capitate them and then come back in and, you know, pick at them every day. Okay. And I'm not trying to be difficult. I'm very involved in PACE and I love PACE.
Right.
CMS has gotten unbelievably into the weeds on PACE to the point where I think it's just really difficult to run a PACE program. It's all well intentioned, but you know, you just can't, you know, you got to give people the ability to go run their companies without. On the other hand, with things like star ratings, if I were at CMS, not my job, but I think star ratings have had a huge incentive. A lot of plans, I know a couple plans that went from 4.5 to 3.5 this year. That's a huge hit. Star ratings are a big deal, and they drive a lot of behavior, and they drive a lot of money. If you're worried about prior auth, then maybe you should put in the star ratings a big piece of, you know, how sensitive, how many complaints, what's your complaint percentage versus prior auth. Because if you're, you know, Scan or Humana, pick a plan, and you go from 4.5 to 4.0 for anything, you're going to flip out, and you're going to fix it. So if your prior auth is too tough and you're going to lose a ton of money, you're going to lose 4% of premium because you went from 4.5 to 4.0 or 4.0 to 3.5. You make damn sure that next year it gets fixed and your prior auth is going to be more balanced. So I think there's a lot of things you can do. I would be worried about micromanaging plans to the point where you're in there trying to run them. And the whole goal is to set broad parameters and make sure they don't abuse things. And if they behave poorly, when I was at CMS a long time ago, I threw United Healthcare out of a couple of markets because they were, you know, they had excessive deductibles and co-payments on dialysis and a few other things. And, you know, they weren't very happy about it at the time. So as CMS, you got to make sure that people are doing the right thing. And as the plans, I think it's a high volume, great business. It's going to keep growing and you got to stay between the lines. But CMS has to make sure that they tell you what the lines are.
Right. Carolyn?
How do you see the push and transition for value-based care impacting all of this? Like, will it impact the way we think about utilization and all of those previous items that you talked about?
You know, it's one of my other pet peeves, value-based care. Everybody has, if I go to one more value-based care council, I'm going to throw up. So I don't go, I'm too old. I don't go. Value-based care is a new name. Nothing's changed. Medicare Advantage is value-based care. Everything that's not the government fixing prices and paying the same provider, exactly the same provider, the same DRG or the same RVU is value-based care. Anytime somebody on the Treasury is at risk, that's value-based care. And there's nothing new about it. I'm glad people are talking about it. I'm glad that we're pushing value-based care, you know, down to the provider level and doing more subcapitation. But, you know, ultimately, you know, if you do pre-acute bundling, post-acute bundling, which NaviHealth was, and then do acute bundling and bundle them all together, what's the ultimate value-based care? Medicare Advantage or an at-risk health plan. So I think the idea that value-based care is new is kind of like, you know, it's a renaming of something that's been around forever. It makes people have conferences feel better. But I worry a little about value-based care. I don't mean to pick on this, but, you know, the basic concept of Medicare Advantage, and this will really cause some people heartburn, was an 85% MLR. What's the MLR? If you're a big health plan and you're subcapping, you know, you're subcapping, which a lot of them do, 3 or 4 different tiers below you, and you're basically the plan doing the advertising and you're subcapping doing ACO and 3 other plans, and you got, you know, 5 other risk takers below you, what's your actual medical spend? Is it 85? Is it 75? It's 60? I think that's a big issue we're going to get into. And I think subcapping and value-based care dim below is a really good idea. But the basic idea was, there's got to be a limit to how much you can take out of actual medical spend.
So, Tom, for those who aren't as familiar with subcapping, could you kind of walk us through that at a little bit higher level?
Without getting killed, probably not, but I will. No, I mean, the ultimate, it's a hell of a company. They've done an amazing job. I mean, I represented Metropolitan and Travelers, maybe the two worst health plans in the history of health plans back in 1993 and 1994. Then they merged into Metro Health, and they kept merging, and they're now United Health. That's where it came from. I don't know if anybody knows that history. So United Health has done an unbelievable job. I pick on them, but they've done a spectacular job of handling the growth of these public programs. A lot of consolidations. It's a machine. It's a well-run company. But when you look at, it's not just United. I don't pick on that. But you look at any of the big players, and you say, great, you're the MA plan, but you're also subcapping to a whole bunch of docs, and you're subcapping to other providers that you own, and you're taking risk on that. Determining how much money you're actually spending on Medicare when you're actually subcapping to yourself, it happens with everybody. I mean, if you're Blue Cross if you're Anthem and you're in Virginia, where I happen to live, are you subcapping out to Inova and a bunch of doc groups? Yes, but at some point you got to look at what your real medical loss ratio is.
And just explain what you mean by subcapping, if you would.
You're taking risks. So if you're taking the $15,000 premium, just to make up a number, from Medicare, you're going to a group of docs and saying you have X number of patients, and we're going to give you 90% of the premium or 85% for those patients, and you're at risk and you're going to manage it. So you've subcapped the risk to them. So you may be saying that the way I set it out, I'm spending 85% of my $15,000 on healthcare, but I've subbed out to a group of docs, and maybe I've subcapped out to 3 or 4 physician groups, and those guys have subcapped back out to Landmark or somebody else, and all these different value-based groups are in there trying to find ways to drive down. It's great that they're driving down costs, but at some point you got to look at what the underlying true healthcare spend is, because the original idea of the program was to spend 85 cents of the dollar on healthcare, not on 15 different subcaps. That's not a popular view, by the way, if you're in the plans, but I'm saying that having been around from the beginning, the basic idea of Medicare Advantage was to have a medical spend. And I'm a huge fan of it. There's nobody in the world that's a bigger fan of Medicare Advantage than I am. I just want to make sure we don't kill the golden goose.
Right. So one other, question that I often run into, and as you know, I teach, graduate public health at NYU and at CUNY. There's the concern that, value-based care or others, it's the, private enterprise getting into healthcare. It's going to drive out the true people who are committed to this for public good, et cetera. But, one of the things we always run into is that it's really following the money, following the reimbursement. That's where you see things changing and things being done. Would you agree with that?
It's complicated. I've been dealing with it for years. Obviously, I ran the Federation of American Hospitals for 6 years in the 90s, the for-profit hospital. So I've dealt with that for years. Which is better? Columbia Presbyterian or HCA. I mean, they're different incentives. I mean, if you have a really well-run nonprofit health plan or a really well-run nonprofit hospital, and you don't have to pay taxes, and you're not as worried about margins for shareholders, that's probably a wonderful thing. But I've also observed a lot of hospitals around the country for the years that were run by a hospital administrator who'd been there for 30 years, and the board was his buddies and car dealers, and there's very little oversight. And they printed money, and they paid no taxes. So, I mean, the nonprofit model, well, when it's run appropriately, is a wonderful, great thing. The for-profit model is also a great thing. I think I happen to be a big fan of HCA, and I think they've done a good job. I think Humana's done a great job, and so has United. They got to make sure that they're regulated appropriately, and got to make sure the responsible people are running them. But I don't think one model's better than the other, and I don't mean to pick a fight with the nonprofit things, but as a general matter, my observation is, capitalism works. And the idea, God forbid, that capitalism could be alive in a capitalist country and 20% of the economy, to me, is kind of laughable. I mean, I think nonprofit is great. The only part of our economy where the nonprofit sector is really dominant is healthcare. Healthcare has not been a model of efficiency, and some could argue that's part of it because there haven't been the right economic incentives. So, if you went back in tomorrow, as I said, the same argument would be, can you imagine the evil, terrible people at Kroger's and Safeway running grocery stores and making a margin on a public good like food? It's outrageous. We should have the Department of Agriculture run all the grocery stores. It would be so much more efficient. And it's basically the same argument. Those are the two goods the government has to provide, really: food, housing, and healthcare, the three. And you can debate all day which is the most efficient way to do it. My view is capitalism and markets do it better if they're well regulated. But I think the nonprofits have to be well regulated too. I mean, I have a lot of friends that run big health systems, that are wonderful. And, I think Intermountain Health, for example, is a really well-run system, has been for years. You can go through lots of them, Baylor, Scott, and White. So I'm not sure one model is that much better than the other. They're just different. But I think the idea that capitalism in healthcare is an evil, terrible thing is, can you imagine capitalism in the United States? Holy shit, that's just a terrible thing. We should have the government building cars. I think forget Elon Musk. Let's have the government build electric vehicles. See how that goes.
I'll let you follow that one up, Carolyn.
I do want to just pause and say to the audience, we are accepting comments and questions. So please, if you have any questions for Tom, add them to the chat. We'll happily look through them, and we would love any collaboration with the audience we can. Go ahead, Jeff.
Jeff, by the way, just one last question, because you're a great guy. I've talked to you for many years. CMS is a wonderful, fabulous place. And when I was there, I would say, you know what? Every one of you guys ought to be forced to do like an internship for a year out at some nonprofit or for-profit, somebody out in the healthcare system. And I would say, in academia, for example, same thing. I mean, how many people, like a lot of people, including Uwe, who I loved, would pick on me about healthcare stuff all the time and say, Uwe, you're a great guy. Why don't you go work at a hospital for a year? Why don't you go work for an insurance company and tell me, it's very easy to sit on the outside and tell everybody how inefficient these things are when I think there are too many people in the healthcare regulatory world who've never actually had a job in a healthcare system or insurance company to know what's going on.
So Tom, you have a long and storied career in healthcare investments and in healthcare. If you were to try to make one or two changes for the future of where the system is going, whether it be regulatory or whether it be in reimbursement or private or public, what one or two things would you change now?
When you get out of these jobs 20 years later, you spend the next 20 years thinking about all the things I should have done when I had the chance. You get too busy. So, I spent most of my 3.5 years cooking up Medicare Advantage and Part D. But I think there are a couple of really egregious, I would gradually keep moving where I think I know Ron Wyden, because we talked about it for years, keep moving towards a comprehensive Medicare Advantage, a federal employee health benefits type model, because I think that's where the world's going. It's going to, but I think if you're a hospital administrator and you're looking out at, Syria, Columbia Presbyterian, New York Presbyterian, and you're looking at payments, you got Medicaid coming at you paying 60, 70 cents on the dollar. You've got Medicare Advantage and Medicare coming at you paying 95 cents on the dollar, maybe 98. And then commercial payers and ERISA, which is a real mess, even a bigger mess, is paying you 140 cents on the dollar. But you don't have the system does not make a lot of sense. You got different payers coming at you depending on your payer mix. It's just crazy. At some point, we've got to have Medicare, Medicaid, commercial, ERISA should all be in one plan with, similar payment rates. Hesitant to kind of what Maryland tried to do, but I think Maryland's made some mistakes in my opinion. But I think I would go in that direction. The other thing I would do, which will really cause a lot of your people to go nuts, is my pet peeve for my 18 years in the government. And I love Medicaid, but provider taxes, intergovernmental transfers, Medicaid is now about a $700 billion a year program. And there's not a single human being in the United States, I can promise you, at CMS or any place that can tell you what the real match rate is for every state. So because all these states have these, it happened over 25 years, every state's got dish taxes, intergovernmental transfers. The state of New Hampshire, I was on the board of Dartmouth Med School for years, and I love New Hampshire. I love Dartmouth. New Hampshire doesn't put one penny in its Medicaid program. In fact, they pull money out of Medicaid for general revenues because they're so good at these transfer payments. West Virginia and Alabama were two of the first to do it. So when you're looking at a big program that's really the safety net program of the country, and every state has a different deal and they don't care about it, and they don't know what the real match rate of Mississippi is the poorest state in the country. They actually pay probably 80%. The federal government pays 80%, Mississippi pays 20% of their Medicaid program. But there are lots of states that are 95-5, or as I said, New Hampshire, 100% federal. Why is that right? That you have a $700 billion a year program and nobody asks what the relative equity in the states are. And nobody cares because every state's out there trying to do their own thing. And this started happening in 1989 on my watch, and I did my best to slow it down. I don't blame anybody. If you're a hospital, you're like, oh my God, we're so reliant on IGT and DISH and all these things, and every state will be killed without it. But at some point, somebody's got to sit down and say, here's the 50 states, and over the next 20 years, we're going to come up with fair, equitable distribution of this money between West Virginia and Mississippi and Massachusetts. It's not right to have the single biggest. Medicaid is now bigger than Medicare if you put together federal and state. And the fact that the biggest actual spending program in the country, because Social Security is just a distribution program, nobody has any idea what the structure is between the 7 territories and 50 states is complete madness. It has nothing to do with it being anti-state or anything. It's just, at some point, why should New York have a totally different deal than Mississippi, or California have a totally different deal than South Dakota? It just doesn't make any sense.
Yeah, I think that's very interesting. That's definitely a subject for another time. We will have someone next week to talk about redeterminations, but the Medicaid pay structure, is certainly something to look at.
No, the redetermination. If you manage to look at the redeterminations, I would guarantee if you looked at how aggressive the states are on redetermination, the ones that actually pay some significant match rate, probably very anxious to do redeterminations because they're going to save themselves money if their budgets are in trouble. The ones that have basically 100% federally funded, they don't give a damn about redeterminations. It's all federal money. They're happy to keep it. Does that make any sense in the biggest program in the government? I don't think so.
Yeah, I don't know if you know, we'll have, and we'll talk about it in a sec, but we'll have Andrea Maresca from HMA on next week to talk about redeterminations, and we might be able to pose that question.
One of my daughters, York, HMA, great place.
Tom, we did get a question in the chat for you. This is from Don. What can or should be done around the deceptive advertising for Medicare Advantage plans that causes much of the confusion during the enrollment period?
Well, I think CMS is, I'm a big fan of having brokers and people give information to seniors, but the reality is it's hard for seniors to know, what they're doing and get information. The broker should be forced to basically give to look at every plan the same, and the broker should not be getting paid differently or incentivized differently to go to Humana or United versus. And the CMS took a couple good steps in that direction a few weeks ago, and I think I think seniors are confused. I think the advertising is okay, as long as everybody you call on the phone is obligated to say, here are the 12 plans in your region, and here are the facts, and here's your doctor, and here's your pharmacy, and this is the best one, and that their incentive is to take care of the patient, not the insurance company. So I don't have any problem with the ads. I have a problem with the directiveness of the program, and I think CMS does too. And being a massive fan of the Medicare Advantage program, I think this is a critical thing to have fixed. And I've said that to Sherry Rice, who runs the program, and to Chiquita, and I think their heart's in the right place, and they're trying to do the right thing. But they need to make damn sure that the patients and the beneficiaries are the target of all this, and that what they're getting and their direction they're getting is fair and objective.
Well, thank you, Tom. You've been most generous with your time. We really appreciate, I'm
guessing your audience understood about 1/50th of what I just said, so I apologize.
Well, we've been posting some terms in the chat, and we're happy to go through it with anybody. But maybe next time we can get you to come out of your shell a little bit.
Yeah. Once you get old, you don't care anymore. You just say whatever they think.
Well, Tom, you've been great as usual. I look forward to catching up with you at JP Morgan, and we'll have to see how that national championship game turns out. But thank you so much.
I have a son-in-law from Michigan, so I have to root for Michigan no matter what. But anyway.
That's gonna be a tough one.
Yeah. All right, guys. Thanks a lot.
Thanks, Tom. We appreciate it.
All right, see you.
Thanks, Tom.
So we will skip since we had such a long interview with Tom, we were going to skip our quick hits and discussion today. We will thank you very much for joining us. We really do hope you've enjoyed our discussion with Tom. As you can tell, Tom is a very straightforward guy, got a lot of opinions, rooted in a lot of deep experience. But do encourage you to, please take another look at this. If you didn't follow any of it, please feel free to reach out to us. Kind of dovetailing with some of Tom's comments, I did a presentation last week at the Wagner Health Network called Defining and Delivering Value-Based Care, which does touch on some of the questions around Medicare Advantage. Please do request that via the contact page on our website. As you all know, Healthcare Strategy Bullpen, we like to think of ourselves, Healthcare Strategy Bullpen is our firm. We like to think of ourselves as the Rosetta Stone between the culture and language of healthcare and technology. We help you adapt and deploy healthcare technology to improve the lives of your patients. As we were talking about with Tom, please do join us next week when we'll have Andrea Maresca of Health Management Associates with us to talk about Medicare redeterminations. And with that, I will say thank you very much and turn over to Carolyn.
Great. Thank you so much for having me, Jeff. I learned so much today. It was so fun talking to Tom. Please, everyone on the line, subscribe to Diagnosing Healthtech by scanning the QR code on the screen right here. You can get weekly invites to the show that way. Our show is also sponsored by Redox. We are the healthcare integration platform that specializes in the implementation of big data, AI, and cloud computing. Feel free to reach out to us if you've got an integration problem you're looking to solve. For all of us at Diagnosing Healthtech, thank you so much for watching, and we'll see you next week.